My name's Hat. My pronouns are they, them. I'm a survivor, researcher, and campaigner, an artist, amongst various things, and have been kind of working on this research for probably around 18 months or so, with the support from the team at Ensign, which has been brilliant. So I'm just going to talk a bit today about like the process of the research and the kind of key findings. And then, yeah, as Amy said at the beginning, then we'll do some questions and things at the end. So yeah, the only other thing I wanted to mention is that every time I talk about this, because it's like I'm talking about the research, I feel like I use like past tense a lot. And it was starting to make me feel uncomfortable because I'm under like no illusion that these experiences are happening, have like changed. And I think it sounds a bit jarring sometimes. So just I wanted to acknowledge that. Okay, so the background to the research. This was based on a kind of starting point of my own experiences of spending quite a lot of time in different mental health wards. So probably just over a couple of years, if you added it all up, kind of from when I was a teenager. And I had really negative experiences of these time periods, kind of like generally anyway, but also like specifically around having my periods while I was in hospital. So I generally found that things like pads or tampons were locked away, or they were kind of prohibited as risk items. Even if they did have them, I generally was too kind of anxious and too unwell to ask staff members for these, so would just kind of end up going without, or kind of having to try and make do with like wearing the same pads for like too long a period of time, or like using tissue paper and stuff like that. The other thing that I experienced was that my periods was not something that staff ever like kind of talked about, or that I felt was considered, even though like for me at the time I did have quite a lot of difficulties around like managing my periods, and a lot of like difficulties, so kind of due to a combination of things like my trauma experiences, having an eating disorder, and kind of sensory needs and things as an autistic person. I also found like particularly periods where I was very unwell, I would find it really difficult to kind of keep on top of the self-care with changing like period products and things, because of like, yeah, just being very unwell and in crisis. But it wasn't something that there was ever space to consider. And so from this starting point, I wanted to understand more about other people's experiences, and to use this research really as a kind of campaign to highlight the need for change and action, to kind of improve people's experiences in these very restrictive places. So yeah, that's kind of where the motivation to do the research came from. And then looking at what existing research there was on the topic, there was kind of a real lack of research, or kind of policy or guidance around supporting patients who are menstruating in hospitals. So there wasn't kind of, yeah, very clear research around this already, but also the literature that there is kind of around people's experiences of mental health inpatient services generally also doesn't consider the topic of menstruation. So even the studies that really specifically look at like women's experiences of restrictive practices and things like that don't kind of, generally the majority of them haven't mentioned anything about menstruation. So yeah, it's just very much kind of an area that is overlooked. So throughout the talk, I'll talk just a little bit about the definition of menstrual health, which I used for this research. So this is a definition that was developed by the Terminology Action Group for the Global Menstrual Collective. So this is a definition which kind of outlines the various domains of experiences that kind of need to be considered in order for somebody to achieve and attain menstrual health. And this was like a really useful kind of definition for the research, because I used this to structure the questionnaires and interviews, and kind of support participants to consider each of these aspects. The definition in itself was kind of developed to support policy and activism to have this kind of clear definition which is used consistently across different across different kind of research or campaign efforts and stuff like that. By the way, I also just wanted to say, I should have said this earlier, but the pictures that I'm using in the slides were all kind of shared by people on Twitter and kind of represent a range of different mental health settings, and are kind of used to illustrate some of the things which were shared through the research as well. So the methodologies for the research. So I started with doing some questionnaires. So these were conducted online, and there was 101 participants who had experiences of menstruation and being in mental health wards. And then I had 67 responses from staff members, so people who work in mental health settings. Just to mention as well, this research very specifically focused on experiences within England, which was kind of because the policy context and like commissioning processes are different within the UK. And I wanted to kind of focus specifically on the kind of one context to avoid there being too many differences in experiences because of the different commissioning processes. And it also supports the kind of subsequent actions to kind of support change, because again, the commissioning processes and inspection processes are slightly different. But as I'll come to a little bit later about the kind of future actions and things that need to happen subsequently, like after this research, and obviously considering experiences more widely across the UK will be one of those. Just a side note. And then I did 10 interviews, which were all held online, and were again with people who had lived experience of spending time in hospital and having periods. I also submitted freedom of information requests to 52 NHS mental health trusts. So there are 52 in England who operate inpatient mental health services. I didn't manage to get responses from all of those, but was able to analyze the kind of policy documents which I did get back. And so in terms of ethics for this research, I received ethical approval from the NHS Health Research Authority, so the NHS research ethics basically. So the questionnaires, which was the first part of the research, included both open text questions, so people could just sort of write in exactly to describe their experiences, but these also included kind of very simple scale questions. So these were questions where people rated their experiences on a range of on a scale of 1 to 5, with 1 being very poorly, being very poorly supported, and 5 being supported very well. And this is just one of the charts which came from that. So the lived experience responses are in orange and staff in red. So this kind of highlighted that generally, so nobody said that they felt that their needs were supported, needs related to menstrual health were supported very well. And only 9% of the staff sample thought the same, which is really quite low. Across all of these questions, the staff samples seemed to kind of gave their services slightly higher ratings than the patients did. And there kind of could be quite a few reasons for this. The staff sample couldn't be seen to be like necessarily representative of like all staff, and things like that. But it also seems to show that there might be sorry, let me start again. That could also show that staff aren't necessarily aware of the extent to which patients' needs are not being supported. Yeah, so yeah, and then in terms of the kind of domains of different aspects of menstrual health, which I spoke about a couple of slides back, the area which was rated as being the least supported with was access to information, which was interesting. So I analysed the kind of the free text responses to the questionnaires and the transcripts from the interviews using a process that's called thematic analysis, which is a kind of structured process of analysing lots of qualitative data. So this goes through a process of identifying like patterns and themes within the responses and within the data that's been collected, and sorting these into what's called codes, which are kind of categories which represent the kind of same idea. And then within that, those are then sorted into themes, which we've got displayed on the screen here. So that related to kind of, yeah, the sort of themes which people were presenting in their responses. So these were then organized into the kind of overarching themes of institutional and interpersonal contexts, which kind of just reflected the influences on people's experiences that were described. So the institutional kind of related to the restrictive contexts and restrictive practices and rules within the inpatient settings. And the interpersonal context was a little bit more about how the interactions between staff members and patients, and the support that patients did or didn't receive, how that kind of shaped their experiences as well. Obviously, there's kind of a lot of overlaps, but for the purpose of the analysis, this is the kind of outline of the themes. And I will go through each of these a little bit more in a minute. So just to quickly describe some of the things that came from the Freedom of Information requests. So one of the things was that I asked services whether they provided period products for patients. Most said that they did, but 6 services said that they didn't provide these on some or all of their wards, and that they would expect patients to purchase their own, which is interesting when someone's sectioned and not able to leave the hospital. It is quite a difficult thing to do. But yeah, and the other thing that I looked at was kind of the observations policies. So this related to like when patients are on either like one-to-one or have intermittent checks from staff. None of these mentioned, they all kind of, or the majority of them gave some kind of reference to patients' privacy, but didn't particularly outline anything specific about menstruation. I also looked at the equality impact assessments which were associated with these policies. So this is basically a tool which is to consider how, like whether a policy has any differential impacts for any groups based on a series of protected characteristics. 20 of those policies said that there were no differential impacts for any group at all. So any things like gender or ethnicity or religion, nothing like that. So yeah, I think that kind of generally showed that those had been done as a bit of a tick box exercise, but not very much consideration had actually gone into those. Okay, so so this was the first theme that I'm going to talk about, which was around the access and availability of menstrual materials. So just to clarify, when I use the term menstrual materials, this is a term that kind of encompasses the different items and resources that somebody might want and choose to use to support them to manage their menstruation. So that includes period products, but also things like medications or hot water bottles or other kind of hygiene and toiletry items. Yeah, so firstly, people described that there wasn't sufficient provision of menstrual products and menstrual materials. So often period products were not provided at all. Sometimes patients were given kind of completely unsuitable items such as incontinence pants or maternity pads. The period products that were available were often described as being cheap or uncomfortable or poor quality. So this was often either very, very thick or very, very thin and poorly absorbent. So these just weren't suitable for people. Often they didn't meet individual needs and preferences. So whether that was kind of a preference for, some people explain they have a preference for using tampons over pads, but it was only pads that were available to them. For some people, this was difficult because of sensory needs. For some people, particularly those who described having very heavy menstruation, the poor quality pads that were provided really didn't meet their needs because they were so inabsorbent that people were needing to change. They just kind of weren't suitable for absorbing people's menstrual blood at all. People also described that medications weren't available because they weren't in stock at the hospital pharmacies. In some cases, this was things like oral contraception, which if people were using this as a kind of treatment for things like PMDD, this meant that upon admission, they would kind of start menstruating and it would then have a kind of knock-on effect on their mental health. Then the other part of this theme around access and availability of menstrual materials was around the restrictions and rules that were in place. So often people explained that they had experienced period products being withheld as risk items. So very commonly, tampons were reported as being withheld as a risk item. People also weren't allowed things like hot water bottles, which left patients feeling in like unmanaged pain because this was something that they used to support their pain usually. And having that withheld really left people in pain. Generally, these rules were what's called blanket restrictions. So rather than being assessed on like an individual basis or in response to a particular risk, they were just kind of implemented for all patients. And then there were also some really horrific experiences where people were left without underwear, clothing, toilet paper, things like this. So sometimes when people were sort of forced to wear anti-ligature clothing, they had underwear removed, they weren't able to use any period products. There was one of the interview participants who shared that because the anti-ligature clothing wasn't available in her size, she was just given a blanket and nothing else. No underwear, period product, or any toilet paper, or even a toilet actually, because she was in seclusion. So there was some really, really huge infringements there on people's rights. And then the last part of this was about the loss of independence, privacy, and control. So people found that because staff controlled the supplies of period products, they had to like ask each time this was needed, which kind of necessitated like sharing when kind of implicitly sharing that they were on their period, which people found quite intrusive to have to do. And yeah, created a lot of like logistical issues as well. And because a lot of patients were kind of explained that they felt too anxious to ask staff, again, they kind of were just left having to go without. Yeah, so the next theme was about how kind of leads on a little bit from that last part about the impact on privacy. So people spoke quite a lot about experiences of being on one-to-one when doing activities like washing, using the toilet, changing period products, and how people found it very intrusive to have somebody observing that them whilst doing those things. Even when people were on kind of intermittent observations, so like every 10 minutes or 15 minutes, participants still described this as very intrusive because they would kind of have to plan when to use the toilet or when to change period products to avoid having people walking in on them. People also spoke about how the kind of restrictive practices and elements of the environment really reduced their privacy. So things like bathrooms not having doors or having kind of only partial doors or curtains meant that staff could kind of walk into the room and see them when in the bathroom. There was also some mention of covert surveillance, and I think that's kind of worth pointing to the wider context of like increasing use of surveillance in mental health wards. So things like CCTV cameras, body-worn cameras, and also specific technology called Oxyvision. So again, all of these are kind of cameras which may be located in patients' bedrooms and sometimes bathrooms in the case of things like seclusion rooms, which again really reduces people's privacy. Yeah. The next theme was about the attitudes and approaches towards menstruation. So this was about how staff interactions and staff attitudes kind of shaped people's experiences. So often participants described feeling that generally menstruation was quite simply overlooked or ignored, that it had never kind of occurred to staff members or the people that had set up the wards that patients would even have periods. And interestingly, this was something that was shared by a couple of the staff participants who, despite having worked on mental health wards for quite some time and having experiencing menstruation themselves, kind of shared that they hadn't particularly considered the topic before doing the survey. Then people also spoke about how there were kind of how on occasion staff would kind of respond with disgust or express very like negative attitudes towards menstruation, and how this made people feel about themselves and their bodies. And then also some of the transgender participants who responded to the questionnaires described how they felt that there was like an added kind of taboo for them, and how there was like an interaction between staff transphobia or staff asking very inappropriate and intrusive questions, with a kind of wider context of how menstruation was overlooked. But there were more, like some people who shared more positive experiences where they'd found kind of staff were supportive and empathetic, and how this had kind of, one person shared that kind of helped her to unlearn some of the shame around menstruation. So I think that really showed the significance of the staff interactions in kind of shaping people's experiences, whether that was positively or negatively. And then just the last theme was about the kind of support needs and care provision that we had. So this kind of related to both kind of physical aspects around people's menstruation, and also like particularly for people who had additional kind of menstrual conditions or gynecological conditions. So things like endometriosis, and how often staff didn't necessarily understand very much about these conditions, or saw it as part of, as being kind of the responsibility of the patient's GP, or kind of saw it as beyond the realm of mental health services. And participants found that very frustrating, because obviously their mental and physical health is very closely interrelated. So where services only kind of considered one of these aspects, it left them feeling very like misunderstood. People's experiences and pain were also dismissed, and in some cases this led to negative impacts on patients' health as well. And then the last part, participants shared some things around how their experiences of mental health or trauma or mental health crisis influenced how they relate to their menstrual cycle. So there was quite a bit of discussion around eating disorders, and for patients who'd had an eating disorder which led to a kind of period where they stopped menstruating, for example, due to a low weight or malnutrition. Participants didn't really get very much support with the like emotional or psychological aspects of this, particularly where their menstruation then returned. So that was spoken about quite a lot, and then also about the how for some participants their experiences of trauma kind of influenced how they related to the menstrual cycle. So particularly finding some types of period pains or using some types of period products to be triggering. But what was generally expressed was that, although again experiences differed, often patients didn't get the support that they needed with this, and felt kind of misunderstood, and as if their needs weren't met. And then also just to mention that there was participants reported that staff lacked knowledge and understanding around PMDD, so premenstrual dysphoric disorder. Often experiences of this were kind of dismissed or ignored or misdiagnosed, and people didn't feel that they were kind of adequately supported with that. But again, there were slightly mixed experiences, and there were a couple of participants who'd had more positive experiences of being kind of supported to identify a kind of cyclical relationship between their mental and menstrual health. And then so following the research, we held a focus group, which was with other people with lived experience of time in hospital and menstruation. And the purpose of this was to kind of review the key points and findings from the research, and kind of combine that with reflections on our own lived experiences to develop some guidelines. So this was to outline some tangible actions that services can take to improve experiences for patients. So the guidelines were published alongside the full research report, and we had some good support from a range of stakeholders who are listed on this screen, but included groups like Minds and Rethink. And yeah, it's kind of, because it's only been, I guess, like a few weeks since the research and guidelines were published, I think it will be it will probably be in a bit more time that we see whether these are implemented into services. But I think by outlining some of the things that can be done quite simply, I do hope that it can kind of lead to changes which will kind of reduce like improve patients' experiences basically. So that was pretty much everything for my presentation. There's obviously a lot more in the research report itself. I speak a lot more about some of the wider issues that this kind of reflects, and kind of discuss the experiences a lot more. But that's a bit of an overview of the findings.